All right. I think we'll go ahead and get started if that's okay with everybody. So my name is Lauren Walter, I'm here with my colleague, Dr. Rachel Skanes, and we're both from UAB. And one of my clinical and research areas of focus is addiction, and Dr. Skanes is geriatrics. So we've combined today to be able to talk to you about golden years, hidden struggles, tackling substance misuse in older adults. No disclosures. What we're going to cover today. So we're going to describe the scope of substance misuse, including opioid epidemic, as well as some others. We're going to discuss some age-specific risk and protective factors for substance misuse and aging. We're going to review some current evidence-based guidelines for screening of substance use disorder in the ED. And then we're going to propose some effective interventions and referral to treatment options for older adults from the ED. We start out with a few cases. Full disclosure, these are not challenging. They're not meant to be tricky. They all, obviously, spoiler alert, they all have something to do with substance misuse or substance use disorder. Go through three of them. Just think about maybe the last time you were on shift and you had a patient like this and would challenge you to ask, did the thought of substance misuse or substance use disorder going on concomitantly cross your mind at all, right? And we'll give you some closure on exactly what's going on with these cases at the very end, but just want to start off by introducing these. So, case number one, 74-year-old male presents to the ED VMS. Chief complains of hip pain after a slip and fall. He's got an obvious deformity on exam in this x-ray, right? No brainer, okay? Case number two, so we have a 67-year-old female, chronic pain, comes in by ambulance and respiratory distress. Her family called 911. They went to go wake her up for dinner, couldn't get her to wake up, and she was snoring very loudly, and that's her ABG, right? So seeing some hypercarbia, some hypoxia there. And finally, case number three, 82-year-old female brought in by family for acute confusion and agitation. These are her triage vitals, little tachycardic, perhaps a bit tachypnic if you're to believe the 20. So keep those in mind as we kind of go through the presentation here, and we'll come back and provide some closure at the end. And I'm going to invite Dr. Skanes up to talk about some basics and epidemiology.
So first we're going to talk about some common myths and beliefs around substance misuse in older adults. So the first is drug addiction is only a younger person's problem, but people can change their substance use at any age. This kind of goes along with once an alcoholic, always an alcoholic, and then an older person may fear stigma that comes from hearing people express these negative beliefs and may not come in asking for help. However, substance use in older adults is a very major health concern. While illicit drug use typically declines after young adulthood, nearly 4.6 million or 8% of older adults live with substance use disorder, according to SAMHSA in 2023, which actually is a 17% increase from 2022. And the ED providers often mistake substance use disorder symptoms for chronic condition or age-related changes, which we'll talk about in a minute. So providers may struggle to identify substance use disorder in older adults because symptoms are hard to recognize, are often nonspecific, and don't necessarily mirror diagnostic criteria. However, there are some risk factors for substance use in older adults that can help providers identify when they come present to the ED. This can be chronic pain or chronic illnesses. They may be increasing use of prescriptions like opioids for their chronic pain, mental illness like depression or anxiety. They may be self-medicating. Functional disability is a big one, so frailty may prompt them to cope with their functional disability, to perform daily activities. Care transition, so if they recently got put in assisted living or a nursing home, they may be lonely, isolated, and are very vulnerable to substance use at that time, and same with bereavement. So pharmacokinetic risk factors with aging, and this impacts not just your therapeutic use, but also the trajectory of their misuse. They have decreased renal clearance and first pass metabolism in the kidneys and the liver, which can lead to a buildup of active metabolites, particularly like bioavailability of morphine. They have more body fat and less lean muscle, which can delay elimination of lipophilic agents such as fentanyl and methadone. And then their total body water is reduced as they get older, so increasing concentration of water-soluble metabolites. And finally, there are specific neurotransmitter changes that can narrow therapeutic index and increase the likelihood of having adverse drug events, particularly with opioid use. Specific to older adults, polypharmacy is a major concern and a major risk factor. So, over 40% of older adults take more than 5 prescriptions daily, which is the definition of polypharmacy, and it increases the risk of drug interactions, particularly the interaction of opioids with sedatives and hypnotics. Let's talk about specific drugs now. So, we're going to first talk about alcohol. So, it is the most used drug among older adults, and the CDC estimated that about 38% of all alcohol related deaths were in those 65 or older, which is a significant portion. Older adults are more sensitive to the effects of alcohol, and then pre existing cognitive impairments such as dementia can impair their ability to monitor how much they're consuming. Epidemiology, so 1 in 20 older adults have alcohol use disorder, and actually one study predicted that up to 30 to 50% of older adults admitted to the hospital identified of having alcohol use disorder. And the warning signs, although pretty non-specific, if you take them collectively, really should point you towards possible alcohol use disorder in older adults. So that's like acute functional and cognitive decline, poor self-care, missed appointments, more ED visits, recurring falls, GI problems, so GERD, gastritis, esophagitis, and uncontrolled hypertension. And so opioid use in older adults, so they did not miss the opioid epidemic. It affected them as well as younger adults. About 15% of older adults were provided an opioid prescription within the last year, according to the CDC. And opioid misuse in older adults is significantly increasing in recent years, even up to over 200% from 2006 to 2014. And this increase in opioid use increases their risk for ED visits for falls and fractures, particularly hip fractures. And so, although opioid use disorder is less than 1% in older adults, they are impacted just like the rest of the population. Even Medicare suggests that this number has actually recently tripled. So, older adults actually accounted for 15% of admissions related to heroin use, according to NIDA, within the last few years. Benzodiazepine dependence is actually pretty specific to older adults. So, unlike opioid use disorder, benzo use is significantly higher than younger populations. 25% of older adults use benzos, and the highest rates are those 80%, 80 plus. And women are disproportionately impacted. And benzodiazepines can also lead to falls, cognitive impairment, and even death from overdose. I'm going to pass it back to Dr. Walter.
Great. So now we've got a little bit of the background in epidemiology. Let's kind of dive into some of the presentation and management plans. So in general, when you think about older adults and just think about all of the side effects from all the substances amplified. And so that's a lot of times how they present. And while this initial red flag swath here, if you're seeing an older patient for a mood disorder or a cardiopulmonary issue, cognitive impairment, that's a pretty broad swath, but you've got to kind of keep that red flag kind of waving until you've kind of ruled out any impact from substance misuse or substance use disorder. If we're talking specifically about opioid use disorder, again, adverse effects amplified in this cohort. So you're going to see decreased gastric motility, which may present as refractory nausea, vomiting, constipation, even perhaps as severe as fecal impaction or bowel perforation. So what should be our first steps? So ask, right? So if your bells are going off, flags are waving, first step is to really doing some screening and identification to ask. Right, so there are a number of useful formal screeners out there that have been validated. The Audit C is a 3-question screener that identifies those at risk for harmful or hazardous behaviors. The CAGE, which we're all familiar with, is 4 questions, really valuable when screening for dependence. If that's too much for you, it's too much for me, and you're too busy, you just want a single question screener, there's a couple of single question screeners that have been validated as well. One specific to alcohol use disorder, one specific for other illicit substances. Again, at the end of the day, just ask and kind of see where that leads you. Of course, screening is the first part of SPUR, right? Night screening, brief intervention, referral to treatment. I think that's something as emergency clinicians and practitioners that we've gotten a little bit more comfortable with during the opioid epidemic as it's kind of found its way into our front and back doors, right? So screening, ask, and then explore that a little bit more. If your screen's positive, you should be asking a few more questions to kind of sort out how it might be impacting them, how it might be impacting their presentation. And then you get into the brief intervention, right? So a little bit of motivational interviewing. This doesn't have to be complex or deep or time consuming. And we do it with more than just substance use disorders, right? We do it with diabetes, taking their medication, hypertension, taking their medication, just exploring their personal motivations to treat their disease process. Patients are used to the pain scale. On a scale of 1 to 10, how bad is your pain today? Oftentimes I'll flip it and say, on a scale of 1 to 10, how motivated are you to hear about or seek treatment for your substance use or misuse today? Most people, 10 being, take me to rehab right now, 0 being like, doc, I'm done talking about this. Most people aren't going to be at a 10. Most people aren't going to be at a 0. You're going to catch them somewhere in that contemplative state, and you can have a conversation with them and potentially offer them resources for the next step. So next steps, what are the new next steps, particularly in older adults? Another spoiler alert for you. Unfortunately, there haven't been a lot of RCTs or cohort studies that look specifically at the older population. And so a lot of what you're going to hear is going to be similar to that which we apply into the younger population. So alcohol use disorder treatment in particular, things to consider. So they're more likely to require hospitalization. They're going to require more aggressive observation for DTs or seizures. They're probably going to have other comorbid conditions that you're going to have to consider or treat for. Use CWA just like you would with a younger cohort, but really consider kind of trying to stick with those shorter acting benzos that are a little bit kinder on the liver. The last two are kind of evidence-based recommendations that are put out there. I've never had to resort to it myself, but I'm going to throw them out there for y'all for consideration and discussion if you want. If you're still having trouble controlling agitation, there's some recommendations that you can use first-generation antipsychotics to help with that. And if you're still having trouble with hypertension and tachycardia, with extreme caution, you can consider beta blockers in this cohort. ED-initiated AUD. So we're starting, there's a lot going on with ED-initiated MOUD, or ED, for opioid use disorder. Now there's another wave coming where folks are starting to consider treating for alcohol use disorder from the ED. Again, the approach here is not dissimilar to the younger cohort. Naltrexone is the preferred drug of choice. Acamprosate has also been shown to be effective, but hasn't been as well studied, and so I would probably push you toward naltrexone. Disulfiram, if you're going that route, I would use extreme caution. It can have tachycardia and hypotension in the older folks. OUG treatment, again, we're going to prefer the Suboxone and the methadone, and then Suboxone more than methadone in this cohort. What's interesting about older adults here is that they actually probably do better than their younger colleagues when they're put on Suboxone treatment, but they often have to be on it for longer. Okay, so don't shy away from using MOUD in the older cohorts. Again, pushing you more towards Suboxone. Probably tell them about a longer course. They tend to do better. Another kind of caveat of the treatment of opioid withdrawal is that a lot of times before they reach that steady state, we give them adjunctive medications, kind of what we used to fall back on before Suboxone, stuff to kind of help with their withdrawal symptoms. And so if you're considering providing these adjunct medications in this older cohort, use extreme caution, right? So I would avoid clonidine if you can. Again, this causes a increased risk of postural hypotension or falls. And I would avoid benzos as well. And generally I avoid benzos in any of my OUD patients unless they're being admitted for more severe withdrawals or observation. So I'll let Rachel wrap it up with treatment.
So, although the idea that older adults are unwilling to seek treatment or services for substance misuse is false, there are certain barriers that make this population less likely to seek treatment. These barriers include negative attitude from providers or family, denial, lack of knowledge, and then lack of provider awareness. So, if they do get plugged into treatment or linked to treatment, it's really important to get the caregivers involved, as there have been studies that have shown that it enhances retention and improves their treatment outcomes with recovery and through the for substance misuse. And then approximately a quarter of substance use treatment programs in the U.S. do actually offer tailored services for older adults. This is a treatment algorithm or wheel for substance use in older adults. It's more complex than younger adults and includes a number of comorbidity and social considerations. So I'm not going to go through all these, but it is important to also consider all the comorbid conditions and that this is more complex than a younger adult that you're going to refer. So let's go back to our cases. So the 74-year-old male that presented by EMS for hip pain after a slip and fall. So you work in an ED where in triage they do substance misuse screening, and so he was positive on his cage. So in talking to him, he did seem a little bit confused, and it turned out to be from alcohol intoxication. You got an alcohol level. He got admitted, he went to surgery, and then the addiction team was consulted and he was plugged into rehab. For case two, this 67-year-old female with chronic pain by EMS comes with respiratory distress. It's always important to get collateral history from family. So you called the family. They said that her pain has been uncontrolled over the last week. So without consulting her physician, she's been taking more of her chronic opioid medication, which led to this overdose that you see here. Of note, respiratory effects show up a lot faster in older adults than the analgesic effects of opioids. So they really have to use opioids with caution because they're a high risk for respiratory depression with opioid use. And then finally, this 82-year-old female that came in by family with altered mental status and confusion. She was visiting for Thanksgiving. She forgot to refill some of her chronic home medications before she came, one of which she said she occasionally uses Ativan for stress and sleep. Turns out she uses it every day. She did not have her Ativan for sleep that night, and so she'd been out of it for 2 days, and she became acutely altered from benzodiazepine withdrawal. And we're just going to talk very briefly about other recreational. So, although older adults are much less likely to use illicit drugs, recreational drugs, than younger adults, this pattern does seem to be changing. The national survey data does show that the rate has increased from about 2% to 10% in the last years. And actually, the baby boomers are more likely to use the psychoactive medications and drugs, probably from the 60s and 70s. But so just things to also keep in mind. And to wrap things up, just some major takeaways. So, the ED can play a very major role in identifying, stabilizing, and initiating treatment for steps in referral for substance misuse in older adults. It's often an overlooked but major public health concern. So, you always want to keep substance misuse on the differential. Screening is definitely the first and most important step for identifying it. And then the evidence does support treating it for older adults and tailoring it to some age related needs such as comorbidities. And then finally, we really need a lot of future focused research with considerations for treatment approaches and efficacy of treating substance use disorder as it pertains to older adults in order to kind of guide more evidence based recommendations. And thank you. Does anyone have any questions?
I just had a quick question on the comment about using opiates, obviously very cautiously in the elderly population. About the respiratory depression prior to pain relief, could you speak a little bit more to that? I have not thought of it. I'm a pharmacist in the use. I haven't thought too much of it at that angle, but it's like, are you suggesting that you almost would hit respiratory depression before you get any benefit?
I think that, yeah. So in our hospital, we initiated a like opioid stewardship committee, and as part of that, we have like ED page or a general page that providers can go to. And one of them actually has like a respiratory depression screen on there for if you're going to initiate opioid use for any adult like that's hospitalized, but it has a higher percent like points for older adults that they're at higher risk for respiratory depression because before they even get the analgesic effects, especially for like oral doses, they or higher dose like IV doses, like with the PCA pump, they are seeing that they're having more respiratory depression before they start feeling the benefits. And so they are recommending that we put these patients on like end-tidal CO2 if you're going to initiate chronic opioid use in the hospital for like any type of our surgery patients.
And in any patient, you're going to develop a tolerance to the analgesic effects before you do respiratory. So you may have some pain relief, but maybe not sufficient, so you can have another, and then you're not really.
Yeah. Okay. Cool. Thank you.
Anyone else? All right, thank you.